There we go. Those are your objectives. So the things we're going to talk about today. All right. Definitions. Because we've noticed a little bit of lacking knowledge. We're going to go through some of these. So, otolaryngologist. That is your surgeon. They do surgery on ears, nose, and throats. Okay? They do surgery on endocrine type neck things. So like the thyroid. But when you have an endocrinologist, that is medical. They do not do any surgery. None. They're like the thyroid doctors or the endocrine doctors. Okay? Like the kidney doctors, like the nephrologists versus urologists. Okay? So otolaryngologist is the surgeon. Endocrinologist is the medical doctor. So if I say in one of my test questions or test answers that it is a surgical procedure or a procedure in general going to an endocrinologist, is that going to be a correct answer?
Yeah.
Right? I love that one. It should be 100%. Well, thank you for being on. But, and then audiologists, they are the ones who specialize in hearing. Okay, they're the ones doing your audiograms. Okay, they're the ones, the ENT doctors, the otolaryngologists can also fit you with hearing aids, but they will utilize the audiologists to do those hearing tests. Okay, those are 3 specific ones that have that, you know, same kind of similar specialty, but one's a surgeon, one is medical. All right, thyroid. This should not be new. Okay, your thyroid sits in the middle of your neck, anterior surface, kind of hugs your trachea. It is very vascularized. Okay, it bleeds a lot when we have to do resections, and it is surrounded by a lot of very, very important structures, like the carotids, the internal jugular vein, okay, as well as your airway is directly below it. So when we do surgery on this organ, it is very, very tiny microscopic type surgery sometimes. It can be very, very delicate. Okay. The other thing that is really, let's see if this one has it, I don't think it does. The recurrent laryngeal nerve. Okay. That is one, you see it right kind of right behind the thyroid. That's one that we damage a lot. Unfortunately, we try really, really hard not to. But if we damage that nerve when we're doing resections or trachs, we can actually damage their vocal cords to the point where it doesn't work anymore and they lose the ability to speak, or it gets hoarse or something like that. Okay? So that is the most important nerve in this bundle. When you think about the pathology or physiology, sorry, of the thyroid pituitary axis, I would know that. Okay, it should be review. When we go through the thyroid releasing hormone, goes down to thyroid stimulating hormone from the pituitary down to the thyroid, who then releases T4, T3, T4, okay, which then tells the body I need more TSH or I need more TRH. Okay, this loop will not be the last time you see this. It won't be the last time you see it on a test. The PANCE loves this axis. And when you're talking, and hypo and hyperthyroidism is a very, very common thing that we see in primary care. Okay, so if you can understand this pathway, how to treat it gets easier. Okay. All right. So we're going to start off with just solitary thyroid nodules. Nodules meaning they are not cystic, they are solid masses, okay? Just solitary, that's one of them. We need to make sure if that nodule is doing anything, whether it's benign, malignant, hot, or cold. Okay? We need to know if it's actually causing symptoms. It could just be that it's a little tissue growth, which is fine, okay? Really, some of the differential diagnoses that you have to start thinking about are benign goiters, thyroidal cysts, thyroiditis, benign malignant tumors, and then metastatic tumors to the thyroid is pretty rare. One thing in the history you should be looking for is duration of swelling, any recent growth, localized or symptomatic swellings or symptoms. So are they having hoarseness of voice? Are they having a hard time swallowing? Does it hurt to swallow? Okay, is it a huge goiter and it's actually compressing their trachea and they're having a hard time breathing? Some of the other things that we really want to take note of is age, gender, place of birth. Okay, because certain places of endemics, you know, if they're in a third world country, they were born there, they may have an iodine deficiency, meaning they may lead to goiters. Okay, family history and any history of radiation to the neck. This is extremely important. The history of the radiation to the neck, this is, which we'll see in another slide, is one of the causes of thyroid dysfunctions later in life, or thyroid cancers later in life. So we need to know if they've had any history of radiation to the neck. If we're thinking cancer, more likely to be a woman, and most likely to be under the age of 20 or over the age of 60. Alright. So, back in the 40s and through 60s, we loved to give children radiation for treatment that didn't need it. We soon found out that it was causing a lot more issues than it actually helped, so we stopped that. Okay? But because of that, people who were children in that age now have an increased incidence of papillary thyroid carcinoma and other lymphomas. But if they've had any, so radiation treatment for Hodgkin's lymphoma is a common treatment, but if they've had that in their 20s, they're more likely to get something else in their 60s. Okay, like this papillary thyroid carcinoma. When we talk about family history, normally we start seeing it with the medullary carcinoma with men too. So when you're actually examining them, how do you examine the neck? How do you examine the thyroid, right? You stand behind the patient. You act like you're about to choke them. No, you don't. You're trying to feel the sides of the thyroid. Okay, you're asking them to swallow, seeing if it's nice and mobile. Okay, you're feeling if it's, you know, if you can actually feel it, if there's any nodules there, any round little jelly beans kind of thing. Okay, you want to look at the adjacent lymph nodes. If that nodule is hard, fixed, most likely possibly malignant. If it's firm but mobile, like a jelly bean that's just sliding underneath the skin, most likely benign. Again, like I was talking about in the physical exam, you're looking for stridor, tracheal deviation, or any JVD, which can happen. Alright. You have to do a thyroid function panel on everybody that has a thyroid nodule. That is the first step, always. Okay? We have to know if that nodule is doing anything in that patient's body to cause them any hormonal imbalance. Okay? So there is no imaging. Labs are always first. So we get T4, T3, TSH. Okay? You can also get thyroid antibodies if you think that this is more cyclical, or you think that they may have like Hashimoto's thyroiditis or that kind of thing. Okay? Which is common. And if you have a low TSH with a high T3, T4, you have a functioning nodule. It's doing something. Then, once we know that there's something wrong with the thyroid, with the panel, we will do an ultrasound. Okay. The ultrasound will still let us know if there's anything, if it is a cyst, if it is a nodule, or a solid mass. Okay, it's not adequate enough to do benign versus malignant, but then we can go to fine needle aspiration, and that is the first imaging / diagnostic investigation of a thyroid nodule. Okay, I don't really like that wording. It sounded better last night. So you do your labs. Okay, that's the first step. That's the first. Then you do an ultrasound, and then you can do an FNA. If you're already going to do an ultrasound and your labs are abnormal, you might as well just do the FNA with the ultrasound. Does that make sense? Kind of. I think I have a better slide on that. So, other diagnostic stuff. Okay, other imaging that we can do. We can do isotope scanning or scintigraphy. Okay, this is actually using a radionuclide, and it tells us if the nodule is hot or cold. Okay, basically we're looking for if that is functional, just like a PET scan. Okay, is it functional? So most nodules are cold. Unfortunately, cold, normally 20% of them are cancer. If it is hot, meaning hormonally active, it is most likely benign. And again, that will be your TSH is low and your T4, T3 is high. Okay, so hot, benign, cold, abnormal. Most likely cancer. Okay. We can also do a radioisotope uptake, which will radioactive iodine, which will tell us if it's like hyperthyroidism versus subacute thyroiditis. So if it's hyperthyroidism, you'll have low TSH, but an increased radioactive iodine uptake. If it's like subacute thyroiditis, your TSH is low, but you also have decreased, so both are low in uptake. If they have a family history of MENS 2 or medullary thyroid carcinoma, these are the things that we want to do. We want to do a metadephrines and a urine catecholamine test. And we want to do a serum calcitonin and a complete metabolic panel. Okay, we're looking for a FeO, and we're looking for a hyperparathyroidism. Okay? Alright. These are just like review. So when you have MENS 1 or Warner syndrome, okay, 90% of them have the hyperparathyroidism. They have pancreatic islet cell tumors 60% of the time, and then pituitary tumors with MENS 2A or Supple syndrome. Those are your medullary thyroid carcinomas. There's FeOs and there's hyperparathyroidism. And then if it's MENS 2B, it's medullary FeO, multiple mucosal neuromas, and then the glioneuromatosis of the GI tract. Okay, and you also with MENS 2, you have that marfanoid appearance. Okay, that's just a breakout of if you have family history of these are the things and the percentages of chances or rate that you might have or that you should be looking for. Okay, just review. All right, so when do we want to go into surgery? Okay, when do we want to take these nodules out? So if we have suspected or proven cancer on the final aspiration, okay, if it's papillary, medullary, or follicular neoplasms, we can't differentiate between adenomas and carcinomas. That final aspiration is just, it's suspected, it's unequivocal, or if there's any atypical cells, we're going to just take that nodule out. Any hormonally active nodules, we'll take that out. Cystic nodules that reoccur after 2+ aspirations. So we've already drained it twice and it's already come back. We will take it out. Okay. If it's functionally malignant, or if it is really big and causing cosmesis issues or breathing issues or swallowing issues. So all of these reasons are reasons why we would take that out. This chart is a lot. If you like charts, I like to leave these in here. Okay, it's everything that we're kind of talking about, but in a chart format. Read it at your own risk, at your own rate. Okay. If you have any questions on it, we can talk about it. But again, this is just review. All right. So you have a 30-year-old female patient with an early or easily palpable and firm nodule on the left side of her thyroid. It measures approximately 2 centimeters. Which of the following is the most appropriate next step for management? Who wants 1? Who wants 2? 3, 4, 5. Okay. Lab. Gotta get labs first. Always get labs first. always get labs first, okay? If I have in the question that the labs were done, then what's next? Ultrasound, then what's next? FNA, good. Okay. So, again, first step, evaluating a thyroid nodule is to assess thyroid function. Okay, TSH, if it's low, do a radioactive iodine uptake scan. If TSH is normal, then you can do ultrasound and the final aspiration would be recommended. Okay. FNA is the best measure for determining histopathologic diagnosis. Okay, so these nodules are normally easily able to get an FNA on, and if we can and we can prove it, then it's the best diagnosis or best tool that we have for diagnosis. Okay. Does this make sense? Does this easier to understand? Okay. I told you, endocrine's hard. All right. Benign tumors of the thyroid. So we have basically two-ish, right? We have the follicular adenoma. It's just tissue hyperplasia, okay? It's tissue overgrowth. It's surrounded by a fibrous capsule, maybe hot or cold, okay? So it's just basically a overgrowth of the follicular tissue, but it's benign. Okay. Then we have a toxic adenoma that is a hyperfunctioning thyroid nodule. It's overproducing T4, T3. Okay. Most likely in females, most likely a hot nodule. If it's greater or if it's less than 4 centimeters, we can do that radioactive iodine. If it's greater than 4 centimeters, or if it's failed aspirations, then we can go to surgery and remove it. Okay. All right. Malignant thyroid nodules really appear early in adult life. Normally a solitary nodule. So this one falls outside of the 20 and 60. Okay, less than 20 greater than 60. It's like early adulthood. Okay. More likely malignant in the male patient. Oh, that doesn't make sense, does it? Early adulthood, but elderly. I missed that last night. I want you guys to know this. So, get rid of the early adult. I mean, so this is a hard one because it can appear, it can start as a nodule and then progress depending on previous like radiation therapy. Just know that it presents as a solitary nodule, most likely malignant in the male patient, elderly, and people who have had previous radiotherapy. Okay, forget the early adulthood. I'll change that on the slides. That just makes it confusing to you guys. So, moving on to tissue type. This is where it's really more important. Okay, papillary versus follicular. Those two are. There's actually 4 different types, but papillary, follicular, medullary, and aplastic. Those are the 4 types. Papillary and follicular are the most common. Okay, papillary being the most popular. How I remember this is papular, popular. Okay. So 85% of the cancers of the thyroid, papillary. They're multifocal, they're unencapsulated, and they spread by lymphatics. Okay, the most popular type of tissue in thyroid cancers is papillary. Then we have follicular, it's the 10%. Okay. It's solitary, it is encapsulated, and it is spread by blood. Okay, it's homogeneous spread. These like to spread to lung and bone. So going into these a little bit further, the papillary thyroid adenocarcinoma, okay, like I said, 85%. More common with iodine deficiency in children and post-radiation patients. Usually multifocal, they spread easily, and through the lymph, and this requires surgery. We normally either have to do a lobectomy, so take half of the lobe that the thyroid that it's in, or we do a near total or a total thyroidectomy, depending on if it's spread or not. Okay. When we get into follicular neoplasms, mostly are benign, but FNAs really cannot differentiate between follicular adenomas and follicular carcinomas. So most of the time we just we go to surgery. We do a partial thyroidectomy, and that specimen is sent to the lab while we're still in the OR. Okay, the patient's still asleep. They do a frozen section. They look to see what the cells are. If it is an adenoma, we close. They go back. Okay. If it is follicular adenocarcinoma, we complete the actual thyroidectomy and then close. One of the things about follicular, they love to go to bone. They love to metastasize to bone. Okay. So, papillary goes to surgery. Well, both go to surgery. Papillary depends on where it is. Follicular, you have to go to surgery. You have to take an actual tissue biopsy, send that to pathology, and if it is an adenoma, we end the case. If it is a adenocarcinoma, then we complete the thyroidectomy. Okay. All right. Moving on to the more rare ones, so medullary thyroid carcinoma, only 5 to 10% of thyroid neoplasms. They can be multifocal, multilobular, lobular, and metastatic. Mostly not familiar, okay? But it is part of the MEN2 syndrome, and we check calcitonin for this one, okay? Loves to mix to the liver, and it causes hyperparathyroidism. We treat this with a total thyroidectomy. We have undifferentiated or anaplastic thyroid carcinoma, really poor prognosis. A lot of times we'll just do a total thyroidectomy. Okay? We can do a partial, but most of the time we do total. In terms of adjuvant therapies that we do for thyroid cancers, thyroxine, okay, it replaces the hormone and suppresses the metastasis. Radioactive iodine, we do this after thyroidectomies. It reduces recurrence and increases survival, treats recurrence in mets. And then local radiation, I know it sounds weird, radiation causes it, but we're treating it with radiation. But we do that for local invasion, recurrent metastatic disease, and unresectable masses. Okay, and then always chemotherapy. Alright. The patient presents with a gradually enlarging throat lump and back pain. The patient is subsequently found to have lesions of the bone, which likely metastatic. Related to the thyroid malignancy found during workup, which most likely is which of the following is most likely malignancy? Who else? 1, 2, 3, 4, 5. Good. Okay. What's the medullary go to?
The liver.
Liver. Okay, so follicular is bone, medullary is liver. Okay. Mediastinal masses, so that's basically the thyroid. Okay. In a next slide, I'll go through what you guys are for primary care. But let's move on to mediastinal masses. Okay. So in the mediastinum, remember you have an anterior, middle, and a posterior. Okay, going front to back. Depending on what part you're in of the mediastinum, depends on where you're actually going to be seeing certain things. So if your anterior thymomas are really common, okay, you can actually have a substernal thyroid, so it develops below the sternum. If it's in the middle, you have to think lymphoma or bronchogenic cyst. And if it's in the posterior mediastinum, a neurogenic tumor or a bronchogenic cyst. Okay? The biggest ones are thymoma and the substernal thyroids and the bronchogenic cysts. Those are the ones you'll see most common. Okay, so thyroductal or thyroglossal duct. Okay, these are benign conditions. We mostly see them in children and young adults. It's an embryologic development through the thyroglossal tract, but it persists as a cyst. Okay, these are hard to treat. They always have recurrent infections. So you'll have this little mass on the anterior surface of their trachea, and it's just recurrent infections. You can't ever get it under control. Okay. Do not do an IND on these. Okay, send to an otolaryngologist. We can do an ultrasound, we can check their thyroid functions, but most likely we're going to treat with antibiotics, then do surgery to correct that. Okay, so don't try to IND those. Like, you really shouldn't try to IND anything on the anterior neck. There's a lot of structures that you can get in trouble with. All right, goiters. So there's physiological conditions, there are endemic conditions, so iodine poor regions, and then prolonged exposures that can cause goiters. Okay, tendency to form nodules within the goiter. If you have a congenital defect in thyroid hormone production or Hashimoto's, you're at more likely risk to get a goiter. If we give them thyroid hormone, normally responds really well. If they are some of the symptoms, excuse me, some of the symptoms you have to be aware of. This is where I was talking about, like the dyspnea, the dysphagia, and venous obstruction. Okay, if it gets large enough, they can actually do a lot of obstructive type symptoms. It can also be poor cosmesis. Most of them in diffuse goiters, the surface is going to be just large and smooth. You can have, but most of the patients, though, by the time they see best, it'll be pretty multinodular. Okay. Thyroid function is usually normal. They're normally not in a hypo or hyper state, but the TSH may still be suppressed, and the radioiodine uptake may still be increased, leading you to have a hyperthyroidism. Okay. But normally TSH is normal. Okay. So when do we go to surgery? We do it when it is large enough that is causing obstructive type symptoms. Okay, we want to relieve the pressure on the system. We always send that goiter to pathology to rule out cancers. Okay. Some surgical complications, bleeding. Like I said, there's a lot of blood vessels in there. It can get very, very bloody very, very quickly. Okay. Injury to surrounding structures, that recurrent laryngeal nerve, like I talked about, we can cause hoarseness, we can paralyze the vocal cords, and we can damage the parathyroid glands that are on the backside of the thyroid. Infection, just due to where it is high. Respiratory obstruction, edema, and pneumothoraces because of where we're at, depending on how big it is. Okay. We can throw them into, if we take enough of it, hyper or hypothyroidism, and then poor cosmesis. Okay. All right. Hyperthyroidism. You all should have had this in endo. Okay, remember it's a thyrotoxicosis. The hypersecretory goiters, Graves' disease, and toxic multinodular goiters and Plummer's disease. If it's left untreated, you can have progressive profound catabolic disturbances and cardiac damage, which then leads to the thyroid storm, heart failure, severe cachexia, and then death. Okay? So, gonna walk into your clinic and what do you see? You're gonna see someone who is nervous. They're gonna have increased diaphoresis, heat intolerance, tachycardia, palpitations, fatigue, and weight loss. They may have a flushed and a staring appearance. They may be exophthalmos, okay, having the eyes that are bulging. Okay. The skin will most likely be warm, thin, but moist, and the hair is going to be fine. When you're looking at the Achilles reflex time, okay, we're not just doing the Achilles reflex for shits and giggles, okay? If its reflex is shortened, it's really hyper. It may be hyperthyroidism. If it's a prolonged, it's really lax. It doesn't. It takes its time. They may be hypothyroid. Okay? That's what you're looking for when you're doing that. Now, with hyperthyroidism, that thyroid storm, okay? You have the pretibial exedema. You may or may not have vertigo, but you're going to be hyperpraxia, so hot fever, right? Tachycardia, cardiac failure, neuromuscular excitations, delirium, jaundice. Okay, that is a thyroid storm. They have to, their TSH is extremely low, and so you need to give them TSH. No. This is why I hate cardio. Yes. Yeah, so I hate endocrine. Sorry. Oh, I feel bad, guys. I'm sorry. This will be the worst lecture, I promise. So, diatoxicosis, suppresses TSH. That's right. Elevation of T3, T4. Okay. So when you have hyperthyroidism, your TSH is low. It is backwards. Okay. But you then have an elevation of T3, T4. Your body's trying to trying to excite the thyroid to give out more TSH. So your body's trying to give it more T3, T4. Okay. How we can test it is if you have somebody who's really borderline, you can try to do a T3 suppression test. Okay. Hyperthyroid patients fail to suppress that thyroidal uptake. Or you can do the TRH test. Okay. I probably will not ask about these things. This is all stuff you've already been taught. Okay. I want to know how you diagnose and how you treat surgically. Okay. So this is just kind of a review thing, hopefully. Any questions on this? I know this is hard to get through. No? Okay. Don't lose faith in me. So when we have this, what are we going to do? We're going to give thiamazole. Okay, 30 to 100 milligrams orally daily. Okay, the old standard was PTU, not very used anymore because of the side effects. Okay, so now we just do methylthiazole. We can do radioiodine. Okay. Basically, what this does is kind of kills the thyroid, okay. Making them either euthyroid or hypothyroid. Okay. In those people who need to have emergency surgery for thyroid storms, okay, we do that by we have to give a beta adrenergic blocking agent prior to, and then we can go in and do the surgery. Okay. Those are only for people, we only go and remove the thyroid in a thyroid storm, or if they're, you know, having close to that death type picture. Okay. Otherwise, we try to treat with methylthiazole. Okay. All right. So, primary care responsibilities when you have thyroid nodules. Do the labs, so TSH, T3, T4, CBC, CMP. If you want it, they're on there. Thyroid antibodies, that's fine. Okay. Send them for an ultrasound, get a chest x-ray. Where you're going to refer those patients, you can either do endocrinology or internal medicine if hyperthyroid, especially if it is difficult to control or thyroiditis is present. Okay, but those nodules, larger goiters, and the thyroglossal duct cysts, you're going to send to general surgery and ENT. Okay. All right, moving on to parathyroid glands. All right, there's 4 parathyroid glands in the back of the thyroid, 2 on each lobe. You can differentiate them by site, but it's pretty hard. Okay. Again, this is good to just help you understand that pathway of the calcium and PTH and calcitonin. Okay. I'm not going to review this. Just this is good review. All right. So. Primary hyperparathyroidism. Most likely in females. We detect this by hypercalcemia. Okay. If the calcium is elevated, we order PTH, or parathyroid hormone. Okay. If that is elevated, then they have hyperparathyroidism. Okay. You must have high calcium and you must have a high PTH. Some things that cause hyperparathyroidism. So if you have a hyperparathyroid adenoma, you have single gland hypertrophy 83% of the time. If it's just like hyperplasia, right, you have multiple glands enlarged, or you can have parathyroid carcinoma, which is pretty low in terms of how frequently it happens. If you do have hyperparathyroidism, okay, the risk of dying prematurely is there, so we try to catch this early and try to treat it as quickly as possible. Okay, so these people, this is a good, the Stones bones, abdominal groans, psychic bones, and fatigue overtones. You remember that? Yeah. Right. This is another one that the PANCE loves to ask questions on. Okay. They'll have asymptomatic hypercalcemia. They may not have any of these things. They may just have a recurrent, urinary stone. They may have weird abdominal pains. Okay, but you're gonna have polydipsia, weight loss. You can look for hypertension or heart blocks, bone pain, pathologic fractures. Okay. Someone who falls and they're like, yeah, you shouldn't have broken that, but you did. If that ever crosses your mind, you should probably look at their calcium and their PTH and for cancers, right? It can be anorexic, or sorry, anxiety ridden, okay? They can be lethargic. I had that right. Anorexic, nausea, constipation. They can also be depressed, lethargic, weak. It could be in a psychotic episode. And then we see this with people who have MEN1, the pancreatic gastromas, and the peptic ulcers. Now, there's a secondary hyperparathyroidism that's decreased serum calcium and an elevated PTH. Okay, so primary, you have both increased calcium and increased PTH. Secondary hyperparathyroidism has decreased calcium, but an increased PTH. Okay, we're looking for chronic renal failures, malabsorptions, vitamin D deficiencies, and any medications that would cause this. So, how are we going to diagnose it? We want to do that serum calcium. We want to look for their phosphates, their alkaline phosphatase. We want to look at their BUN creatinine, and then the serum PTH. Okay. All right. We can see this occasionally with hand X-rays. You'll have that subperiosteal periosteal bone reabsorption, because that body is trying to, that's where that calcium is kind of coming from. Okay, it's breaking down the bone, releasing calcium into your body. So it has to come from somewhere. So we can see it in the hands and the skull. We most likely will do an ultrasound. Okay, trying to find whichever gland is the actual offending gland. The advanced imaging, the one we'll do most commonly, is the TC scintigraphy. Okay, so with ultrasound and the scintigraphy, in 80 to 98 patients, that's where we're going to find those preoperative localizations of the tumor. Okay, those two things combined, and up to 90% of patients, we're going to be able to find whichever one it actually is, the offending agent or offending node. Okay, but we can still do CTs, we can still do MRIs, but most likely we're going to do ultrasound and the scintigraphy. Okay, so differential diagnosis for primary benign. Okay, you're going to have adenomas and hyperplasias. If it is a humoral hypercalcemia or malignancy, the tumors produce PTH, okay, mimicking that hormone, or from other cancers that have metastasized to the bone. Okay, so when we look at that, we're looking for sarcoidosis, trabeculosis, certain medications like thiazide, diuretics, lithium, vitamin D, toxicities, aluminum toxicity. Okay, we see this with people who've been immobilized, people in renal failure, adrenal crisis, and familiar hypercalcemia. Okay. This is the same slide as before, reminding you. Okay. All right. So what are we going to treat? How are we going to treat primary hyperparathyroidism? The surgical indications are you have to have significant symptoms of renal stones, osteoporosis, or being in a hypercalcemic crisis. Okay. During the surgery, we delicately try to find, hopefully we have an idea of which node it is, and we try and take that off. And what we do basically is we sit in the surgery suite, we take that gland off, and then we draw their intraoperative parathyroid hormone, and if it stays high, we have not gotten the right node. Okay, we take another one out, we draw another PTH. If it stays high, we did not get the right node. We do another one. Okay, we take that third one out. We basically take out parathyroid glands until your PTH starts to fall. Okay, once we get that intraoperative decrease of the PTH hormone, then we know that we've gotten the offending gland. Okay, now what we can do, which is really cool, is if we've taken out glands that didn't necessarily need to be taken out because we didn't really know which one was the offending gland, we can actually place those other ones back into the arm, like into the forearm, or into the sternocleidomastoid muscle, and you still have the ability to then have a functioning parathyroidism, or parathyroid. Okay, so that's pretty cool. We still will watch them very closely, but this is one where we have to wait in the OR for the lab results to see if we've actually gotten the offending gland. Okay. Surgical complications, bleeding is the biggest one. Like I said, this is very bloody surgery. It can be very bloody. So neck hematomas, acute airway compromises. We have to go back in and do a wound exploration. Okay. That probably means that we've nicked something. We just didn't see it burst open until they were I don't know, the OR. Okay, that recurrent laryngeal nerve can be injured again. We can injure the thyroid. Okay, If we end up taking all 4 or taking enough of the glands, we can actually throw them into hypoparathyroidism, okay? Meaning a low calcemia, hypocalcemia. And that's when we start to see tetany, Chbosky sign, Charbot sign, seizures. Okay, you'll see prolonged QTs on EKGs, hypotension, heart failures. Okay, we can start with IV calcium if it's really severe, and then switch to oral calcium that they'll then be on the rest of their life. So everybody remember what Chbosky sign is? Right? Tell the patient to relax their muscles in their face. You tap around the parotid or on the mastoid, and if it spasms, then you most likely have a low calcium, and then Charbot's is spasming of the hands. Okay. All right, so you have somebody who you think you have a parathyroid gland issue. What is your responsibilities as a primary care? Completing that complete metabolic panel. We want a serum calcium, phosphorus, electrolytes, BU and creatinine and alk-phos. We have to have that serum PTH. Okay. We want to do a chest X-ray looking for other primary tumors or mets, and then referring to endocrinology and or surgery. All right, so you have a 45-year-old female underwent a total thyroidectomy for follicular thyroid carcinoma. I was admitted for observation. The same night the patient endorses tingling and fasciculations of her jaw. What is a complication is as a result of her surgery. What did we do? Who wants 1? Who wants 2? Who wants 3? Who wants 4? Good. So it is 2. So basically, because the parathyroids are on the back of the thyroids, if we don't take them off and leave them where they are, or we damage them when we did the total thyroidectomy, okay, we're going to throw them into a hypoparathyroidism state, and now she's got Chbosky sign. All right, what time is it? All right, we got a couple more. Okay, adrenal glands. Okay, these sit like little party hats on top of your kidneys. They are part of the hypothalamus axis, right? Basically, the hypothalamus will send a signal to the anterior pituitary to produce ACTH. ACTH then stimulates the adrenal cortexes to release these hormones depending on what zone it is in the adrenal. So if you're in the zona glomerulosa, you're going to do aldosterone. If you're in the fasciculata, you're going to be cortisol, and if you're in the reticularis, you're going to do testosterone. I got 'em. Love it. Okay, then it's going to send a negative feedback loop back to the hypothalamus to suppress ACTH, because you have all those good ones, and then the adrenal medulla, so the inside, okay, those are where it actually produces those catecholamines and directly has sympathetic stimulation, your fight or flight, okay, your cortisol. Or your catecholamines, okay? All right. I know you guys have heard me say this word, an incidentalloma. Okay? This is something that we find a lot of the times when we weren't looking for it. Okay? Someone comes in, I see this a lot in trauma, right? I'm looking for trauma, not tumors. Okay? So when we do a CT scan, or what we do a pan scan, head, neck, chest, belly, pelvis, a lot of times we find stuff that we weren't meaning to find. Okay? We still have to follow those up, but those are called incidentalomas. Okay? They're found incidentally. Most likely they're benign, most likely they're hormonally inactive, but depending on what else is going on in the patient, you still have to follow those up. You can't just say, oh, I'm trauma, I don't need to deal with this, right? You have to put it in a discharge summary, make sure you tell the patient so that they can then go back to the primary care and get a workup. So when we're looking at if it is a high or increased suspicion for a malignant mass, okay, you're gonna look for sites. You're gonna have masses within the breast, the lungs, renal. You may have melanoma or lymphoma. Okay, if that mass is greater than 5 centimeters, it will lead you to an increased suspicion for malignancy. Okay, and then can be present if they're in an adrenal failure or Addisonian crisis. You're going to see hyponatremia, hyperkalemia. Okay, their aldosterone is low. They're in a deficiency. Okay, but if they're having hyperpigmentation, they have actually increased ACTH and CRH, leading to an increase in melanocytes. Okay. All right. So, differential diagnosis, what else could it be? So you have adrenal cortical hyperplasias. Okay, these are malignant tumors of the adrenal zona fasciculata. Primary adrenal disease. Okay, you're going to have excess secretion of cortisol, leading to a Cushing's syndrome. The next slide goes through the differences between Cushing's syndrome and Cushing's disease. Okay, but adrenal cortical hyperplasia, excess cortisol, Cushing's syndrome. Okay, when you have a pituitary adenoma, which leads to excess production of ACTH, adrenal stimulation, and an excess of cortisol, you have Cushing's disease. Okay, so if it starts in the adrenals, it's Cushing's syndrome. If it starts in the brain, it's Cushing's disease. Okay. If it's disease, right, if it's a pituitary adenoma, we surgically remove that pituitary adenoma. Okay, if that pituitary adenoma removal fails, then we do an adrenalectomy. Okay, we'll just take that adrenal out. So, say you don't have an adrenal cortical hyperplasia or pituitary adenoma, but you still have the ACTH production. Okay, these are the things that you need to start thinking about. So, small cell cancers of the lungs, carcinoid tumors, and medullary carcinomas of the thyroid. Okay, so if you don't have excess, or if you don't have, like, there's nothing wrong with your adrenals, there's nothing wrong with your pituitary, but you still have this increased cortisol, increased ACTH, you have to be looking at these other things to figure out what's going on. Okay? So again, Cushing syndrome, general condition, having excess cortisol, it's less serious, most likely a tumor of the primary, of the adrenals. Okay? Certain steroids, like if you put somebody on a long dose, either taper or a long history of oral steroids, right, you can actually increase their cortisol production, causing Cushing syndrome. Cushing disease is a type of Cushing syndrome, but it's caused by a pituitary tumor. Okay, way more serious than Cushing syndrome. All right, how about we take a 10-minute break? It's warm in here. Everybody's asleep. Wait, what? Really? What time am I now? What time is it? Fantastic. I can't believe I did 50 slides in an hour. All right, let's keep going. Pheos. Pheos are my unicorns. I have yet to see a pheo, and I want to see one. I don't wish it on a patient, but I want to see one. Okay? So pheochromocytomas, they are a tumor of the adrenal medulla, and they secrete epinephrine. Okay? They, classic triad of headaches, palpitations, diaphoresis. Okay? They will have high blood pressure. They may present with a stroke and or angina. Okay? 50% of patients with MENS 2 may have this. If you have a patient with neurofibromatosis, you must suspect a pheo. Not that they'll always have it, but you have to suspect it. Okay? How do you work it up? You do urine and serum metanephrines. Okay? We do imaging to try to locate the tumor. When we are actually getting ready to take that tumor out, we want to prevent a rebound hypertensive crisis. Okay, so about 10 to 14 days pre-operatively, we'll start them on a alpha blockade and then a beta blockade to try to prevent that rebound hypertension. once we take the FIO out. Okay? Alright. So, we try to confirm that it's a FIO prior to manipulation of the gland, because we can actually cause that FIO to then, if it's still attached within the body and we touch it, it can actually send out epinephrine and really fuck with the patient. So we try to confirm it either by biopsy, or we can do it, of course, in surgery, but we'll try to do the 24-hour urine catecholamines, metadephrines, okay? We can also see it on plasma-free metadephrines. We can see it on CT or MRI occasionally, but the biggest one is the PET scan with the hypermetabolic activity. Okay. So, urine, catecholamines, metadephrines, PET scan with hypermetabolic activity. Those are the two main things that we're going to find it on. Okay. All right. So, if the adrenal mass is hyperactive, not necessarily FIO, but any active mass, right? We're going to do an adrenalectomy, okay? We can either do it laparoscopically or open in an X-lap, which is what we're doing here, okay? If it is metastatic, we will most likely do it open because we want to try to take it in block. We want to take surrounding structures to ensure that we have gotten all of it. Just like we just talked about, hypertensive crisis, if it's a FIO, due to handling the tumor, okay? We can then, unfortunately, after we devitalize the tumor, if we don't plan for that loss of from the loss of epinephrine, we can actually throw them into a hypotensive crisis. This is one that is like that delicate balance. Anesthesia really needs to be on their game with these to help really maintain that normotensive BP with vasopressors and fluid. Okay? So if it's hormonally inactive, okay, if that tumor is encroaching other structures or it's greater than 5 centimeters, we'll take it out. Okay? If it's less than 5 centimeters, then we've confirmed that it's benign. There's no metadephrine, no catecholamines, no excess epinephrine, whatever, then we confirm it's benign. We will repeat the CTs every 3 to 6 months, and then if it starts to encroach or get bigger, we will take it out. If not, we'll just continue to observe. Okay, all right, adrenal gland responsibilities. Okay, we have to determine if it's hormonally active or not. How do we do that? We do a CBC, we do the metabolic panel, CBC or CMP or BMP. We really want to make sure we get electrolytes, okay? Sodium, potassium, calcium, magnesium and phosphate are always ordered separately. And if you want those are good too. We want to know the PTH level. Okay, we wanted possibly dexamethasone suppression test. The serum BMA or metadephrines, looking for the catecholamine secreting tumors, and the urine catecholamines. Okay, we want to have you guys do imaging, so at least have a chest X-ray, consider a CT, or a PET, depending on where you are in your diagnosis, and then refer. Okay, if it's something surgical, obviously refer to a general surgeon. If it's in the neck, you can do a general surgeon or a otolaryngologist. If it is more medically, okay, we're observing, sending to an IM or endocrine, so internal medicine or endocrine is the referral pathway. We made it through it. That sucks. I'm telling you, this is the worst one. This is the hardest one to understand. But we made it through.